Good morning, everyone. Welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for another session. My name is Jackie. I'm a member of the Echo team, and I'll be facilitating today's session. A few brief announcements before we begin. If you've not already done so, please put your name, your email address, and your affiliation in the chat box. Please stay muted unless you're speaking. You may also use the chat for communicating. We realize that Q&A time is very important to you, and we're trying to categorize and address as many questions as possible. If you have questions that are not answered during today's session, we encourage you to submit it as a possible case discussion item for a future session. Remember, the link to submit case items is included in the follow-up emails that we send out, or you can contact us directly at echo@psu.edu. Please remember that if you are sharing a case, no personally identifiable information is allowed. We are recording these sessions, and we will share all materials and recordings after the session. In the spirit of all teach and all learn, which the ECHO model is built on, we'll be on a first name basis during our sessions. Our ECHO sessions always begin with a brief lecture followed by a case discussion. Cases could be a question or a challenge that you want to address. They're a critical component of the ECHO model. So again, we encourage you to submit cases. For today's session, Dr. Andy Probolus will discuss strategies for communicating with family members and visitors. And then we'll have discussions around case questions that were submitted by Jenny Connect Frieda. Thank you for sending these in, Jenny. I believe we're also going to have Dr. Jignesh Sheth from the Wright Center on this session. He's been involved with community and staff engagement throughout this crisis, and he may be contributing, and if not, we are working to bring him in to a future session to share more of his strategies. During the lecture, please feel free to put your questions into the chat. When Andy is finished, we'll have time for some Q&A. We also have a team of specialists from Penn State Health online, and they'll help field questions. But please remember, this is an all teach, all learn environment, so you can share both questions and answers. And with that, I'm going to turn things over to Andy for our brief lecture.
Thanks, everyone. I appreciate you taking time out of your morning to be here with me today and to talk about what I feel like is something that sometimes gets lost in a lot of our discussions about COVID-19 and the preparedness things that we're all doing at our various institutions. And just by way of introduction, my background is I'm a family physician who then went ahead and did a fellowship in hospice and palliative care. And I've worked in palliative care for the last 13 years now. So most of this lecture is not from a kind of global perspective. It's more about the one-to-one interactions that you guys are having every day with patients, families, and sometimes even colleagues when it comes in and around dealing with the current times we're living in and the COVID crisis. So the way I'd like to just start is to just invite everybody during this kind of very difficult time to just take a minute and kind of take a deep breath in and let it out again. A lot of times there's a lot to, especially if you're in healthcare right now, to distract your attention and to kind of get sped up and feel really anxious. Most people are feeling anxious right now, and if you are, congratulations, you're paying attention. This is an anxious time. There's a lot that we have to be worried about, both for ourselves and also for our patients. At the same time, what I'd invite you to do just before I get started with the formal lecture is to just think about all the people who are supporting you and have supported you to get to this point right now. There's several thousands of people that you're never going to meet who are allowing you to be in the place you are right now and supporting you as you continue to do all the things that you do to try to serve the people around you, your patients, and your colleagues. So I think that's kind of a mind-blowing thing to think of. And a lot of times in this culture, we get caught up in our own individual stuff and what we're doing as people without remembering that we're all connected together. And I think, if anything, this whole crisis has been a really stark reminder of that. So I wanted to point to that, and sometimes just feeling the support of everyone around you who's allowing you to do what you can do can be really comforting if you're starting to feel a little anxious about all that's happening. So what I'm going to hopefully talk about is some material for if you're trying to figure out how do you start talking to patients, especially about serious issues. If you have patients who are older, more frail, they have multiple comorbidities, you're concerned about what's going to happen to them if they indeed catch this virus that's going around. Having a kind of systematic approach can really make a huge difference in your ability to get into difficult conversations. And so, as with most things, there's nothing new under the sun. This material that I'm presenting is actually widely available. It's been published by a group out of Seattle called Vital Talk, which I would strongly recommend that you guys check out if you are interested in some more communication tools to talk to patients and families about what's going on and what really matters during this time beyond just, are you getting enough food? Are you taking care of yourself? Those are all really important things. At the same time, we want to be able to do some proactive conversations with people who are vulnerable about what's important to them, and making sure we know first and foremost how they're doing and what their wishes are if they get more ill. And so this set of slides and my presentation here is really with an eye towards that. And I'm probably not going to get through all the material, but it's okay. There's a guide online. You're welcome to access it. It's freely available. So as I said, this set of slides is actually directly from a primer for communication put out by the folks at Vital Talk. It's also available on the Center to Advance Palliative Care's website. And so the first mnemonic that we're going to go over is called calmer. And it's a way to talk to people about what's happening right now and help get to some things that matter to them. So the first, for the C in calmer, is to check in. And it starts with taking a deep breath yourself, because this is going to be a difficult thing to talk about, and you're probably going to be talking to a lot of people about this all day. And check in with the person you're talking to. In this case, I'm imagining you're talking to a patient or family member. How are you doing with all this? So kind of see what kind of response you get back from them at that point. So kind of take their emotional temperature. And then ask about COVID. What have you been thinking about with COVID in your situation? And then again, kind of listen to what they give back to you, what's coming up for them. That will really give you a sense of how they're coping, what they're thinking about, what they're worried about, and will give you another kind of entryway into a conversation to connect with them. And then lay out the issues, which is the L. Here's something I want us to prepare for. You mentioned COVID, and I agree. Is there anything you want us to know if you got COVID or if your COVID gets really bad? This, again, points to, our concern for them. It may be something that's very much on their mind. And it allows you to kind of use what they've been already talking about as a way to get into what we're hoping to talk about as providers or as medical folks. And then the next is M, which is to motivate them to choose a proxy and to talk about what matters. Things take a turn for the worse. What you say now can help your family members and loved ones. And the next question is a really important one. Who's your backup person? Who helps us make decisions if you can't speak? Who else? So having two backup people. So most times patients and families don't know what a healthcare proxy is or a surrogate. Think about framing it in a simpler term, especially for elderly folks, about who's your backup person? Who can we talk to? And then if you can get them engaged with that, we're in an extraordinary situation. Given that, what matters to you about what part of your life, about your health care? Again, this sometimes will allow you to get into what's really mattering to them, what they need to communicate. Some of that can be medical, but some of it may not be medical, and encouraging them to communicate with the people who matter to them about this, especially these backup people, if they have strong feelings about things they want and things they don't. The next part is a little dicier. It's if you have a good relationship with them, you feel like the conversation is going well, you may want to make a recommendation, and only if you feel like, based on your discernment in the midst of that situation, that they can hear it. Based on what I've heard, I would recommend this, and whatever you feel like is the right thing to do, and ask them, what do you think about that? And for a lot of folks who work in palliative care, I have several colleagues on this session right now. A lot of times we're talking to them about serious things like, do you want to go into the hospital? Do you want to go into the intensive care unit if you get that ill? And sometimes we have recommendations about that. And it's important, if you are in a position and you feel like the time is right, to be able to share those with patients and their families. So that's what I mean by kind of making a recommendation. And then at this point, expect emotion. We kind of talked a little bit about this when we just started. It's an emotional time right now. People are stressed. People are a lot of them are not dealing well with all that's happening. And if you're talking about difficult things, people are going to get emotional. And in some ways, that's, for me as a palliative care specialist, that's a reassuring sign that someone's starting to get emotional, because it means they're paying attention. As I mentioned earlier, what you've said has actually had an impact. It's registering with them at some level. And so acknowledging the emotion, helping them to kind of be in that space, creating a place where they feel safe enough to have an emotional reaction in front of you is really important. And giving them some acknowledgement that this can be hard to think about. And there may be grief, there may be anger, there may be sadness, there may be just kind of shock and worry. And having some tools to be able to deal with those emotions in the moment can be really important, because chances are they are going to show up. And then very important for those who are doing this in some kind of a medical context, record the conversation. Create some documentation, even if it's a phone call or phone note. Will help all of us kind of take better care of this person going forward. Say, I'll write what you say in the chart. It's really helpful. Thank you. If you're at a point where they feel comfortable writing something down, like writing down who would be a decision maker, all the better. But if not, that's okay. I think just having something written down for this particular patient is, and family member, get them thinking about that, get them talking about it, is really, really helpful, because we don't want to wait until this person shows up in the emergency room in extremis and none of this information has been captured. Sometimes that happens and we deal with that when it does happen, but as a healthcare system, the more proactive we can be in this time, the more we can help people plan and think and make good decisions before it reaches a crisis, the better off we're all going to be. I wanted to pause there just for a minute and see if there are any questions or reactions to the material so far. Okay. So some more context for this mnemonic. This is under the assumption that we're still in the kind of place that I think most of us in Central PA are in right now, which is we're not at a point where we're completely overrun. We're not in a place where the kind of medical needs of our community have kind of outstripped our resources. I feel very fortunate and that we are in a place where we're still kind of we have some capacity to deal with more people getting sick, and there's been a tremendous amount of work by all of our colleagues at our institutions. I'm sure I can say with confidence Penn State, and I know other folks who are at Lancaster General and WellSpan have put a tremendous amount of effort into creating capacity to deal with sick people who are dealing with the COVID virus. And so people are working really hard to create capacity to deal with an increased number of people who are going to need medical care and potentially even critical care. So I want to acknowledge that as well. The next mnemonic I have is more if you do have the misfortune of being in a place where you're kind of in what I would call a crisis situation, where the needs are kind of outstripping the resources to deal with them. And so this is another mnemonic that allows you to kind of deal with that situation if you have the misfortune of being there. But I want to be real clear from a standpoint of how to care for people. You don't want to go there unless you're actually there. So this is not something you should kind of pull out right away. I think sometimes when we're seeing the distress around us, especially if you're in contact with anybody from New York City, they are in this place. And I was on a call last night with somebody who's in palliative care there, and they are literally having to make life and death decisions all day, every day. And I really hope that as people who live in this area continue to do what we need to do to kind of, what's called flatten the curve. I'm sure everybody's heard about that by now. Kind of slow the spread of the virus, and hopefully it doesn't cause a problem to the point where it's outstripped our resources. So I wanted to offer this. If we get there right now, the state of play for most of Central PAs, we're not there. So it's important not to kind of get yourself in a feeling of scarcity if you don't have to. So this particular mnemonic is called SHARE, and we'll go over that just kind of quickly. So SHARE starts with show the guideline. And so if we do reach a place where we're in a crisis situation, there is going to be a guideline that's created by the institute at the state level as well as the regional level to deal with the surge of cases. And so it's really important to be as transparent as you can once that guidance is provided to you. And so the next is to create a headline. So again, you want to focus on what you will do first instead of things that you're not going to do. And so a lot of this is going to depend on your institution and how they choose to manage the surge situation that they're in or the crisis situation. And so you're going to really need to be in touch with what that means and what guidance they're giving clinicians at that point. The next step is to affirm the care you will provide, and talking about, this is what we're actually going to do for you. We're hoping you will recover. And then respond to emotion. Again, you'll notice this is a consistent thing that comes up in having these conversations. And last but not least, emphasize that the same rules apply to everyone. Again, we're trying to create a sense of equity, transparency, and fairness here in a very difficult situation. So that can be a challenging thing for folks to deal with, but I'm hoping and praying that we don't get to the point where we have to use some of these tools, but it's better to have the tools and not use them than to need the tools and not have them. So that's really the spirit in which this is being offered right now. Any questions or comments on this mnemonic?
Jim, can you
Yeah.
hear me?
Yeah. Go
Jim,
ahead.
this is Ted Bollard from Penn State. In using this mnemonic, and some of these things obviously are pretty stark and in your face to patients. Have you talked to others who have utilized this, and has this been something that they say actually does work well, and people do understand that we're trying to treat people equitably, or we just don't have enough information about usage yet?
I don't know that I've heard anybody directly about the share mnemonic. I have heard from colleagues, and I've listened to podcasts from people across the country who are using the other mnemonic or a variation of it. And what I've heard pretty clearly is, especially for older, more vulnerable people, they are more willing to engage the conversation than I think people sometimes give them credit for. Gotcha. A lot of times they are aware of what's going on. They do know that they're in a place where maybe this is not the time where they want to try to do everything possible to prolong their life at any cost. And at the minimum, they seem very receptive to somebody sitting down with them or talking with them very directly about their situation and how all this applies to them.
Yeah, that makes sense. Thank you.
Mm-hmm.
I would say that while I haven't used this mnemonic, these are also areas that you need to cover as you're implementing your protocols in your own office as well. Your staff need to feel like they're all equally important, that all of their concerns are being addressed, and we're within the resources we have, assuring as best we can their safety too.
It's a great point. Any other comments or thoughts about the material presented so far?
Yeah, this is Peter Rainey. I'm in State College. I work for Penn State Health. I work for the residency there. One thing I like about the mnemonic that I think might be useful, both the first one you shared and this one, is that I think what patients who don't work in healthcare all the time find is that healthcare is very confusing and strange, and in a crisis it's even more scary. And so sharing what to expect, like with the guideline, and telling what you're going to do next, I think orients people to the present and helps them understand that things are being done. And whether you make it through the whole mnemonic or not, at least you've oriented the person and reduced some level of anxiety about the confusion and crisis.
Yeah, I appreciate that. And I think that's really the hope with these guidelines is to, when we're in a place where we're uncomfortable, it's hard for us to communicate clearly. And sometimes we, as medical folks, will kind of start talking too much or making things very medical, start falling into our habits of using jargon and over explaining. And so the simpler and kind of easier you can make it both for yourself in terms of the message you're trying to communicate, the better it's going to go for them and for you.
Jim, can I add just one more comment?
Sure.
Yesterday, I'm sure many of you may have seen the story through the media of came out of, I think, Illinois, about physicians sort of hoarding their own medications for their own care. And I think the last point, the E on this mnemonic, is very important, that people understand that, you know, at least in my experience, that's not occurring. I have not seen that at all. But I think some people who saw this really, you know, people believe what they believe, is to emphasize that we are treating everybody the same.
Yeah, and I think that's really important, and it kind of talks about what we tend to find, which is when you're dealing with stressful situations, it can really cause people to act their best or act their worst. And so it really behooves us as the medical community to be on our best behavior and to prepare well. And then when it actually comes to the point where we need to step up and do things and do them in an ethical way.
Thank you.
Okay. I do have the rest of my slides at this point are, if you are kind of more situation specific, I'm not going to go over all the language in them. But please know that at the end of my slide set, there's a link to the Vital Talk website where this primer is freely available. As I said, it gives you, if people are having questions about screening and someone's worried about they might be infected, and so some of the common questions and ways to respond to those, if you're getting questions about that. There's also helping people decide, you know, where to go. Are we sending you to the emergency room? Are you going back home and you're going to just kind of self-isolate at home? Giving some language in and around that, because those can be sometimes tense conversations as well. As well as if you have to send somebody to the hospital, there could be some fear about that, and both from patients and their family members. The other kind of sections are about counseling and coping, to boost people up or to help them settle down when you're getting a lot of emotion. That can definitely happen. People are stressed out. You know, there's tons of media, and our media landscape is saturated with tons of things that can really scare people, get them ramped up, make them distrustful, as Ted mentioned earlier. And it's our job to kind of have a way to kind of smoothly deal with that, help them kind of come up if they're a little bit on the low side, but also kind of simmer down a little bit if they're kind of upregulated and really hot about what's happening. It's also, you know, we talked about the mnemonics, some other responses if you start getting into what we in palliative care would call the goals of care discussion, what's important to them, what they want, what they don't want, some different ways to respond to a couple of different things you might get from that conversation. So the last page kind of goes along with the share mnemonic. You know, when limitations force you to choose and kind of allocate limited resources, how to respond to some of the things you might get that way. And again, this is language that is specific to that context. This is not language that I would recommend using if you're not in a place where resources are completely scarce. And so you want to be sure that you have kind of a calm way to discuss what's happening. And then also kind of how to deal with fear when people are worried about what might happen. And back to James's point about this can be really helpful with your own staff if you're in an office or you're in another place and people are scared about what's going to happen and what people are worried about. As the third kind of box on this slide, I've been working all day with infected people and I'm worried I'm going to pass it on to the people who matter to me. And so just having some script around how to respond to those questions and concerns can go a really long way to help people kind of get back in their bodies, get back to themselves, remember what they're here to do. And that can include all of us from time to time. And so that's the last kind of set of scripting is around grieving, dealing with loss if somebody's died, or there's just a real sense of overwhelmed. How come we don't have the things we need? Approaching moral distress, which is a big thing for a lot of our colleagues and was even before this crisis, and having a calm way to kind of talk to them about that, help them kind of come back from the edge, come back to a place where they can be thinking about what they need to do and not so focused on what they can't. So in conclusion, remember to care for yourself and those around you. Being more intentional at this time is likely to be very helpful. I've been sitting in on a lot of the Project Echoes, and I've really enjoyed the talks by Dr. Gavin McGregor Skinner, and what he has stressed over and over again is just pay attention to what you're doing. Be here when you're putting on your PPE, when you're taking it off. Be very intentional about that process. You're more likely to protect yourself and protect those around you if you don't get sped up and hurry through what you're doing. So I think taking a little bit of extra time, a little bit of extra care, both in terms of the physical things we're doing like donning and doffing PPE, but also the care that you give to those around you is really, really important in this time. And to Ted's point earlier, we become the model for the people around us, and your kind of approach and your care really goes a long way, regardless of the words you choose and the way that you choose to say them. Thank you.
Thank you so much for that. That was extremely informative and useful. I know that Ellie has shared the link to the resources, and you've provided a lot of great scenarios here. So before we move on to the case, I wanted to see if anyone wanted to go into a little bit more depth on communication in any of those specific scenarios that you mentioned. So I'll just wait and see if anyone would like to contribute or talk around that before we move on to the case. And I'm also going to call out, we have another ECHO program at Penn State with the College of Nursing. It's the 4 M's of age and dementia-friendly care. And in one of your slides, I know you talked about what matters. So I'm reaching out to all of those hub and spokes in the 4 M's. If you have information to contribute, regarding those conversations, please feel free to share them. So if there are no questions or comments at this point, we'll keep fielding them. Please feel free to unmute or put something into the chat. I'm going to ask Jenny, Jenny Connect, who is actually part of the 4 M's program that I just mentioned. And she's going to share a case, and then we'll have some discussion around that.
Hi guys. So my name is Jenny Frieda. I'm a nurse practitioner. I am working on the age-friendly care PA grant with Penn State College of Nursing. Our goal is to enhance workforce, enhance the geriatric workforce. So we also do have, like Jackie said, the ECHO pertaining to the 4Ms. So if anybody would like to ever join us, please do. But so my main question at this time is, in our community, and I live in State College, so we do have a large percentage of older adults in this community when the students aren't around. We see many older adults that are unaware of the risks of COVID, or at least it seems that way. So how can we as a community better educate, reach our older adult population? And I guess I would like to hear other people's take on this. Like, how can we market to them? How can we connect with them? How can we network with them? Of course, all while social distancing.
Erica, can you advance the slide?
Oh, I did put a little bit of additional information in here. So although our stores in the area have all pretty much chosen specific times that high-risk individuals can shop, although they seem to be very heavily populated during those times. But there's still a steady amount of older individuals that we see shopping and doing other activities within our community during, normal business hours at 4 p.m. Other than the news, how can we reach these older adults? And what can we do to better, educate them and help them?
So I see Jumi is mentioning that at the Right Center, they're doing a lot of telehealth visits as touch points. Are there other strategies that are being employed or suggestions for Jenny?
One of the other things that we're doing at our place is that we're actually following suit of the grocery stores. And what we're trying to do is bring in our chronic care patients that need face-to-face encounters, or their desire is for that, during the 8 to 10 hours. And then the second half of the morning, we'll do the healthy young adults and stuff, and the sick call, and we'll do another cleanup between those two, and then clean up at lunch, and start back with the elderly the first part of the afternoon, and then switch to the younger. The only thing that tempers in that is that sometimes the elderly are coming with a caregiver, and so we don't keep all of the young out, but we certainly reduce the degree of exposure. We try and by limiting the number of accompaniment, we decrease the number in the waiting room and encourage the spacing. Rather than leaving music on hold at this point in time, we put a message about it, encouraging people to call before they go to any medical place, and just general information on it. So
Thank you for sharing that, Jim. Great strategies. Others doing similar things or other approaches?
On the palliative care side, we've tried to transition as many of our visits as possible to either telephone check-ins or telehealth. I think the other thing you can do is, if you're transitioning that way and you have your office staff calling people and telling them, we're not going to have you come into the office, we're going to have you stay home, and a provider or someone will check in with you. I think it's a perfect time, as James was mentioning, to give your office staff or whoever's making those phone calls some script to just kind of public service, how it's really important, given who you are and your circumstances, to stay away from people as much as possible physically, but stay connected to them in other ways. And so I think that's the part that we don't want to lose in the midst of this is, in some ways, the physical distancing is important. The social distancing for our older, more vulnerable population is really problematic. And so putting an emphasis on, you don't want to be physically close to them, but you still need to remain connected to your support network and find a way to support each other.
So I don't know if this phrase is useful, but it's a phrase we've been using in the residency. So instead of social distancing, we've been saying distant socializing.
I like that a lot better. I read something yesterday, and I think it may relate to what Jenny has posed, but Andy, I think maybe you have some suggestions on this. I had read where elderly patients that are maybe in nursing homes and are getting information, but maybe not able to fully comprehend what they're being told. And then families are, calling and trying to find out, what's going on there? How do I talk to my father? He doesn't understand this. Do you have anything to share around that?
I think what I would say is, again, here, knowing who you're talking to and using, it's something we think about and talk about in palliative care all the time, is you want to kind of make sure your language is appropriate for the person you're talking to. Especially with elderly folks who have some cognitive impairment, you want to make it as simple and as kind of easy to understand as possible, so that they kind of get what they need from that particular communication and conversation. And this, you don't want to talk down to them or below the level they're functioning. You want to kind of meet them right on their level and make sure the information you're giving to them is appropriate for their level of comprehension and what they emotionally need as well as cognitively need at that moment.
Thank you. I know that Jignesh Sheth is on from the Right Center, and you've been doing a lot with community engagement and outreach. Do you have anything to share for Jenny's question?
Yes. So one of the things that we did that I would like to highlight is we had a community drive-through food drive yesterday. And we had about 650 cars that went by my parking lot, and about 1,000 bags of foods were given out. As a part of this process, each car, when they were going through, they were greeted by a member at a point through the drive-through. They had to check in. They were asked for their name, their information, and asked obviously if they were sick or had any questions about the situation there. And if they were, then obviously we had staffed it with our Right Center staff. Additionally, we had medical residents present there. So we had about 15 to 20 residents staffing these drive-through tents, where if patients had any questions, we were able to answer them and also have them, have the opportunity to learn more about the disease, what we are doing as a Right Center, as an organization, to help them. And we use that as an opportunity to bring people together with an understanding that there has to be safe distance. So we had the police department there who was very helpful and guiding the traffic. We were letting like 4 cars come in at one time. We had a line as long as about 2 miles down the road. And we have an aerial picture. We took it through a drone to see the line. And the thing is, they were coming in 4 or 5 cars at a time. They had the opportunity to check in, ask the questions, if we asked them if they were sick or if they had someone who is sick, and then we asked them to seek immediate help, either from their PCP or with the Right Center. We also highlighted the fact that the Right Center is still open 83 hours a week. We're open from 7 in the morning until 8 at night and 7 days a week, telling the community that we are here for you. And you could be safely seen here, because one of the things we highlighted also is we have a check-in process right at the door, where there's a door for sick patients and there is a door for the patients who are essentially not sick, or at least they don't know that they're sick. And segregating them into different areas has made the patients feel a lot safer, because one of the things we have to worry about is the patients are scared. And nobody wants to sit in the waiting room next to someone who might be coughing or potentially may be sick. So separating them, so we have a separate entrance which is behind the building. The front entrance is only for the well patients, and we are messaging the patients accordingly when they call for an appointment that, hey, if you're sick, you'll be seen through the back door. We have a team there who's in full PPE. Team there cannot come to this side of the building, and this side cannot go there. And then we have deployed runners who go from this side to that side to exchange items as needed. And deploying the teams, having a runner, separating the sick and well, gave a strong message to our patients, our staff, that we mean business, and we really want to continue taking care of the people, but we are also worried about the safety of our staff.
I don't know if it's my internet or yours. I'm losing some of your conversation there. So I'm going to jump in for a second, and
Okay.
I want to reach out back to Jenny. Jenny, is this giving you any insight or some ideas, suggestions around what could be done? Not that we're asking you to do this on your own.
No, yeah, it definitely has. I know in State College, our food bank has already asked for help. So maybe if we could connect with our food bank and do something similar, I mean, I think we would definitely reach more of the older adult population than we already are. So definitely has given us some good ideas. I have one more question. It was included within there. I know there's been a lot of confusion, both with patients and with providers about what is considered a non-essential visit. How are other places dealing with this concern?
At the Right Center, I can say that what we are saying is, if the patient is able to come in, we are providing them a safe passage to be seen without having to be co-located with sick patients. And if they're unable to come, we are offering them telehealth visit. Because like you said, it's extremely hard to define what's essential versus non-essential. Secondly, we also have to remember we are making these decisions at the level of front desk or at the call center level, or the call, whoever takes your calls. And I mean, honestly, those people are not really clinical. And I would rather have them err on the side of caution than the other way. So we are saying everything is essential. We are open here for you. If you cannot come, we then have the provider decide whether the patient needs to be seen absolutely, or can we make a decision to do a televisit. And then we are involving the provider at that point. And most of us really know the patient, and we should be able to then make that decision. But we're not leaving any protocol at the level of front desk or check-in, because I'm concerned that they may miss certain things that may not appear that serious, but it could be a problem going forward.
This is Chrissy Scartosi, sorry, from Penn State Health St. Joseph's. We're doing something similar in that we're actually having, we're having the providers and the residents, all the providers look at their schedules and look at their patients and call their patients, see if there's something they can handle over the phone first. If absolutely not, the provider deems whether it's essential or not. So then they contact our practice manager, Michelle, who's been excellent about trying to get patients in. And we're doing similar where our more well patients or patients that we don't have concern for COVID that we're aware of are coming in the morning. So we're trying to stack those in the mornings and then have our other patients who maybe are concerning, have cough symptoms, coming in a little bit later. To speak a little bit about some of my thoughts on the geriatric population, or some of identifying some of that concern, I guess I don't really have an answer to it. My thought is, when I had seen, yes, people in the grocery store, but also we had a bingo hall very near my house before it got shut down, and it was amazing the amount of people that were there, because that is their socialization. So my concern is some of those patients that are at home, elderly, more vulnerable, living by themselves, that are now told they can't go out and socialize, but they don't have iPads, FaceTime. I don't know how we connect with them to make sure that they're not becoming depressed. They're not, all these other, outside of all this social isolation that we had before, we were trying to get those people out and about. how we connect with them, whether it's just making a quick phone call from the clinic just to say, hey, how you doing? But that takes a lot of capacity as well.
Thank you so much. I'm actually going to take over for Jackie since she's having some internet troubles. So it looks like we have a couple additional questions that I'm just going to throw out to the group. So the first one from Kelly Hoover. If you have elderly family members and need to become involved with healthcare concerns and questions, how do you do so and maneuver HIPAA?
This is Janice. I can speak as my parents' healthcare power of attorney. You know, I think if it's a family member, you know, making sure that their care providers have documentation that it's okay for you to speak with them. And once that's on file, then family members, so I would encourage, you know, loved ones, family members, and the older adults themselves to try to be proactive about getting that documentation in place ahead of time. And it doesn't have to be a super formal, you know, form. It can just be as simple as calling, letting them know you can speak with my daughter or whatever. Just a simple strategy.
Thank you, Janice. Does anybody else have anything to add to that? Okay, so we have another question here from Lauren. Just wondering if there's any advice for patients with mild dementia dealing with this. And then she goes on to explain that her 90-year-old Nana is in an assisted living facility and made it sound as though she thinks they're the only ones being quarantined. She also became very upset when she was reminded that her mother could not visit her. It's been really hard on her. Just wondering if anyone has run into this scenario.
So this is Dr. Shad. I can answer that. I had a few family members who had the same concerns because they were unable to visit their loved ones outside of certain hours at a nursing home. And I had to bring the family members in and I discussed. I think my message to them was really a quarantine nursing home is probably a lot better than community at this time. Because if they have put the right protocol in place and they're not allowing the visitors to come in, it's really the safest place for their loved ones to be there. One of the other things we also did is we talked to the nursing home administrator to see if they can put a protocol in place where they can stagger family members to come in, so that they only have 5 to 10 family members coming in on any particular day and spread it out across 7 days. And they seemed very open to that. I didn't get a chance to follow through, but that's what I felt, that they were more open to, allowing a couple family members with strict rules that I was able to share the CDC checklist with them of what they should be asking the visitors, or including their own employees before they come into the building.
I think the other important piece that I would add in terms of supporting somebody with dementia who's dealing with this feeling of isolation is a lot of times as healthcare people, we have a tendency to think they just need more information when that may not be what's required at all. Sometimes it's just some presence, some reassurance, maybe even kind of directing the conversation away from that if you know that you've said the same thing to them a bunch of times and it's not getting through. Acknowledging the emotion and the frustration behind it, providing some support to them that way may be just as effective, if not more so, than trying to explain that you're not being singled out or, this is happening to everyone.
This is Janice. I was a former director of nursing in a skilled nursing facility. And I think most good care communities have some great strategies on engaging older adults. So they might have buddy programs where they have a staff member assigned to every single resident, and they check in routinely with that person to check on their emotional level and answer questions. They also have lots of activity programs that they can do either one-on-one or in small groups if people aren't infectious. They can screen for visitors if they've got that set up as part of their policy and protocol. They can also do some Skyping with family members or set up Zoom meetings so that there is some outside engagement. I actually worry more about the older adults that are social distancing at home and, you know, the potential isolation that they have. I was just talking with the director of the Center County Area Agency on Aging last week, and we talked about the need for more programming around helping older adults have access to things like Skype, where they're not as isolated at home, and talking about maybe some undergraduate students or whatever interfacing with them to help set those opportunities up for them. So that's a potential project down the road, but I'd love to hear if other people have other ideas around how to help those that are in their homes.
Thank you so much for those comments. And Lauren, I can totally relate. I also have a grandmother in her 90s who's in a home right now and is suffering from dementia. And it's been about a month since we could see her, and we just wonder how she's doing. She's not really able to speak on the phone, and it's kind of heartbreaking to us to think that she probably feels like her family has abandoned her. So we've been sending her mail, and that's really the best we're able to do right now, but I feel for you. So there's an additional comment here that addressed an earlier question that I just wanted to call attention to from Matt, a palliative care fellow. He mentions that when speaking to some of the medical groups throughout the hospital, they've begun to have a drastic downsizing, and in scheduled appointments for patients in their panels, medical students on rotation have been kept at home. So because there's some additional available time, they're working on identifying elderly patients with comorbid conditions who are at highest risk and reaching out to them proactively. So that's another suggestion to that earlier question. Another really important comment about mindfulness, something to consider. There's a lot of anticipatory grief being felt, and clinics could also communicate their policies to locally elected representatives who have networks. All really important topics, and I love that these have actually come to light during this session, because some of our upcoming topics that we'll be offering over the next 2 weeks will address these concerns. We're working to try to pull together a session that will be geared towards nursing homes. We also do have a session tomorrow that's going to be addressing mental health in a crisis. So stay tuned for some of those upcoming topics. Are there any final questions before we wrap up? Okay, so I do want to remind you all that we have 2 echo sessions tomorrow. We have one at 8 a.m. that will discuss mental health concerns during a crisis, and then at 1 p.m. we'll have a presentation on ICU care. So those reminders will be going out to all of our registered participants. If you have any suggestions for future topics that we might be able to address, please do drop them in chat before you exit today, and we're happy to take a look at those and try to accommodate some of those requests. In addition, please remember that these sessions are CME eligible. The link to that session evaluation has been dropped in the chat box, but it will also be sent in our follow-up correspondence after this session. And as always, we welcome cases for these discussions. It's a great way to make sure that your question is addressed and heard and discussed. And finally, thank you to Andy for being with us this morning and for presenting that really important information, to our case presenters who brought really lively discussion to light. And thank you all so much for being with us this morning. We'll see you again soon.
Thanks,